Good morning. This is Dr. Vegi Suryanarayana, Professor and HOD Respiratory Medicine, GEMS Hospital, Srikakulam. Today I am going to discuss about the examination of respiratory system. Should be done in a daylight, it is preferably, and the sitting position is the best for examination of respiratory system. The respiratory system examination consists of the four components: inspection, palpation, percussion and auscultation, as usual other systems also. Now I will show the inspectory part of the examination. Inspection of the mouth and nose, and see the nose whether there is any abnormality in the nose, like the nostrils may be flaring, nostrils may be pulling inside, that you have to observe, and any other discharge from the nose or nasal cavity congestion or pale mucosa you may observe. So the congestion indicates some infection, upper respiratory tract infection. Pale mucosa indicates that there is a allergy component. You may see the deviation of the nasal septum, which is very common in more than 60% of the people. Sometimes you may be able to observe a nasal polyp. So these are the things you will look for in the nose. And look at the eyes. Some of the times you have to see the conjunctiva and see the pupil, so that sometimes in some of the congenital conditions you may be able to see the dislocated lens, as in Marfan syndrome, and you may see the dolichocephalus on the face, which also may indicate the Marfan syndrome, and so wise. And then you look at the oral cavity. Ask the patient to open the mouth and put a torchlight and examine the oral cavity. In the oral cavity, you try to look at the tongue, oral mucosa, teeth, and ask the patient to pull the tongue forwards and ask him to say ha, so that you will be able to see the tonsils also and the posterior pharyngeal wall. So what are the things you will be able to see in the oral cavity? You may be able to see the tongue. Sometimes the tongue size may be increased, as in myxedema. You may be able to see the teeth mark on the sides of the tongue, which indicates macroglossia. And you may be able to see the staining of the teeth in the oral cavity, which suggests of smoking commonly. And sometimes it may be a sign of lead poisoning also, wherein you will be differentiated by putting a thin film strip between the gums and the teeth. The gums are stained in lead poisoning. The teeth is stained in the smoking. And likewise, you should see the under surface of the tongue also. Sometimes you may see some abnormality of the salivary glands, and you may be able to see the enlarged salivary glands, and along with the parotid gland enlargement, as you see in the Sjogren's syndrome, likewise, which also can involve the respiratory system. So you should be able to have the knowledge over the general systemic diseases also. And then the teeth, you may see the lost teeth and dentures or bad teeth, which could be the forerunners of the respiratory infections. So these are the important things. And sometimes you may see the tonsil also enlarging, pharyngitis and tonsillitis, which also may precede the lower respiratory tract infection. So these are the important things you will note in the examination of oral cavity. Now you examine the neck part. You can see the trachea and sternocleidomastoids and side and back of the neck, and everything you will observe. See here, if I see you are able to see a mass lesion here in the neck, and you are able to see the trachea also deviated. If you see the right sternocleidomastoid, this is prominent. This indicates that the trachea is deviated to right, and to confirm it, you ask the patient to press his chin over the hand. See, the most prominent sternocleidomastoid is on the right side. That means the trachea is deviated to the right side, and you can see the angle between the sternocleidomastoid and trachea is at a higher level here in this side, right side. So this is also is another indication that the trachea is deviated to the right side. So the trachea, the sternocleidomastoid being prominent is called a trial sign, and then you have observed the swelling in the neck. We will go for it afterwards. Okay. Then you will go to the examination of the chest. You see the chest. Usually you have to observe the chest by standing at least 6 feet away from the patient and observe the chest and its shape, size and movements of the chest you have to examine. Anteriorly you have to go to around 6 feet away and observe the each part of the chest. You inspect how it is moving and all, and then you go to the posterior side and see the movements of the chest, and you can see the scapular medial margins getting separated from the going away from the spine also you can observe. By doing that you can observe the movements of the chest, and you can see the drooping of the chest. Sometimes when you observe the both side of the shoulders, you may be able to see the drooping on one side. You see in this case you can clearly observe the drooping of the shoulder on the right side, and also the more winging of the scapula and the reduced movements on the right side. So the most important part in the examination of respiratory system is the movements of the chest, because this is the point which decides the side of lesion in a unilateral disease. If it is a bilateral disease, you may see uniformly decreased respiratory movements, but when it is a unilateral disease or one side the disease is more compared to the other side, you will see the more diseased side to be having a less respiratory excursions of the chest. This is the most important thing every student must keep in mind. This is about the respiratory movements and the shape of the chest. The shape of the chest, you can see so many varieties of the chest. In the chest you can see the chest diameters, anterior-posterior and lateral diameters vary, barrel shaped chest, and the spine lesions, sometimes you may see the spine kyphosis or scoliosis or gibbous, all those abnormalities you may see. And in some of the cases you may see pulsations, abnormal pulsations or abnormal swellings you may be able to see. So you may be able to observe the apical impulse, and you may see the parasternal pulsations. You may see the effects on the right side instead of left side also. These are all the things you may have to look for. So this is about the inspection of the chest. In this case, you are able to see the respiratory movements grossly decreased in the right side. Now we will go to the palpation. The palpation, we are going to confirm the inspectory findings. How to palpate? The trachea, you have to see which side the trachea is deviated. That could be confirmed by using the 3-finger test. You use the ring finger, index finger and middle finger. Keep the index finger and ring finger at the junction of the sternoclavicular joint on either side, and you keep the middle finger over the trachea and try to move it horizontally from side to one side to other side, and choose the most prominent point on the trachea, which is coming most anterior part of the trachea, and see the distance between the middle finger and the other 2 fingers. The distance between the middle finger and the other finger, which side is less, is the side to which the trachea is deviated. Here, if you see, you can clearly observe the middle finger is more nearer to the index finger. So that means it is deviated to the right side. This is one examination. And the other part is try to insinuate the finger between the sternocleidomastoid and trachea, and which side is more resistant. It is the side on which the trachea is deviated. And another thing is you observe the angle between made by the peak angle between the trachea and sternocleidomastoid. Which side the angle is going upward is the side to which the trachea is deviated. That can be confirmed even more pronouncedly by asking the patient to press on your palm and look for the angulation on both sides. See, you can clearly observe the right side, it is at a higher level. That means the trachea is deviated to the right side. And then along with the trachea, mediastinum also moves. So in this case, I expect the apex also to move more medially. So you try to palpate more medially at the side, and here I could see the apex being felt more medially. It is more medial to the mid-clavicular line. That is one thing. And another thing is see the respiratory movements. From the posterior aspect, you keep your both palms on the shoulders and try to keep your fingers to touch at the midpoint, and see the respiratory movements occurring on both sides. If you see, you are able to see the elevation of the palm on the right side and the left side. If you see, the movement is better on the left side compared to right side. Okay. So that indicates that the respiratory movements are decreased on the right side. You can do the same by keeping your hands like this also, and see the respiratory movements on both sides while the patient is taking quiet breathing. And on the anterior side also you can do the same way, like keep the hands like this and try to observe the movements of the chest on both sides. See, likewise you will examine the respiratory movements. And also in the palpation part, you will have to inspect the ribs and the intercostal spaces. You may be able to see the intercostal spaces widening or narrowing in certain of the cases, and you may be able to see the tenderness at various places. And sometimes when you press over the ribs, you may be able to see the cryptus if there is any fracture of the rib. So all those things you have to examine. Here in this case, you see, here the swelling also, because it is there, I am trying to palpate the swelling also. See, this swelling seems to be very hard. The swelling is very hard and not movable. It is fixed to the underlying structures. So this indicates that it is a malignant swelling. And you see, sometimes it is fixed to the muscle also. If you make the movement of this swelling, it is a little bit making a little bit of movement anterior posteriorly, and see the upward and downward movement is not happening. So it indicates that it is also fixed to the muscle. So these are all the things you will observe in the palpation. During the process of palpation, we have examined the patient while he is taking the regular breathings. Now we will try to examine the patient when he is speaking, producing sound. When he is speaking, the sound will be produced in the larynx, and that is transmitted to the chest wall by producing vibrations. Now we will try to feel the vibrations on either side of the chest. For that we will use the right hand palm, whichever the dominant hand is, you try to use the palm and use the ulnar side because it is most sensitive in the palm. So this also we will follow the same rules as we were doing during the percussion. So try to put the palm on the normal, supposedly normal side first and abnormal side next in the corresponding areas. Likewise, it is better to ask the patient to make some word which is usually nasal in nature. It's like 99, 99, 99. They ask him to repeat each time he repeats, you try to see the vibrations that are transmitted onto the chest wall. Here in Telugu people, the uneducated people may not be able to tell 99. So you can ask them to say Nana, Nana, and in the moderate voice, not very loudly or very whispering like Nana, 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 Nana. Likewise in the posterior side also you will auscultate this way while he is uttering the word. Likewise we will see the difference. So that's about the vocal frame test. There are certain conditions where you will see the vocal frame test diminishing. In certain conditions we will see the vocal frame test increasing. So the vocal frame test decreases when the sound is not transmitted to the chest wall. That occurs when there is obstruction to the airways, major airways, or when there is something is lying between the chest wall and the lungs, like air or fluid in the pleural cavity, or gross thickening of the pleura and underlying fibrosis and all, you may find it to be diminished. Whereas in certain conditions where there is a consolidation and big cavity which is connected to the major bronchi, you may see the vocal frame test increasing. So this is as simple as that. This makes the vital capacity, this frame test, vocal frame test done. And you see the vocal frame test a little diminished in the areas where the heart is there along with the lungs. In that area, slight diminution of the vocal frame test you may find. This is about the vocal frame test. For doing anthropometry, we will use two flanks which can overlap from one side to the other side of the chest, both anteriorly and posteriorly. The long flank you should be able to take. If it is not available, you can use the long book with stiff covers. So here we are using the stiff covers, long books. See here, if the patient is asked to hold it without moving, also is okay. But you see from above, there is anteriorly it is more nearer and posteriorly they are more away. So in such a case, what you should do is try to measure the distance between the anterior parts, two anterior parts at the same level. See here it is 5.5 and off approximately, and here it is 13 and a half. 5 and a half and 13 and a half is making 19. You make half of it. It is around 9.5. So likewise you can do that. Now you can take the help of somebody and keep it parallelly. Try to keep it parallelly and then try to measure the distance. This is 10. So it is almost coming as 10. So this is also is one way of always measure the two sides anteriorly and posteriorly and make it half, that is the better. And then anteriorly when you are doing it, you keep the books like this and try to measure the both sides. See, it is 7 plus this side, and I am not able to do it. Actually, it needs a larger, this is also 7.5. So 7.5 into 10, literally. So it's normally the ratio of anterior posterior to lateral is 3:5, 3:5 or 5:7, so something like that. So it's almost okay. Comparatively, there is a little bit of anterior-posterior diameter increase is there, but it is not a florid barrel-shaped chest. This is one important thing. And another thing is you see the respiratory movements also, how much respiratory excursions are occurring also you can confirm with the tape. The one thing is you try to keep the tape horizontally, you should encircle the chest at the level of the fourth or fifth intercostal space. Always see that it is horizontal. You see the other side also. See, it should not go down or up. You observe it clearly, and then you observe the movements that he is making. The centimeters part is better because he is making very little movements. So, at the he is almost making almost 1 centimeter only he is making. See, you see the hemithorax enlargement. Now you can confirm the respiratory movements by using the tape also, and you keep your stent surrounding the chest at the level of the fourth intercostal space. Never take nipple as the marker, because nipple is associated with skin, so it may dislodge downwards in some of the patient. So take at the level of the fourth or fifth intercostal space and see that it is at the same level on the posterior aspect also, and try to look for the respiratory movements. So here it is the entire chest expansion, that is to be noted. And then this is the hemithorax. You keep the other side on the spine midpoint and use the chest at the midpoint of the sternum, and then try to see the respiratory movements on either side. See, this also proves that the respiratory movements is diminished on the right side. So these are the important findings in the examination of the chest. Percussion of the chest consists of two types. One is direct percussion and other one is indirect percussion. Direct percussion, you can percuss over the bony prominences, for example on the clavicles, on the sternum and on the scapulae if the scapulae are prominently there. In these areas you will have to percuss with the pixometer finger. See, when you are percussing over the clavicle, you have to tighten the skin by just stretching it downwards and percuss over the mid part of the clavicle like this. You should always percuss with the pulp of the finger, not with the tip of the finger. So keep that in mind, otherwise your nails will hurt the patient. So try to percuss with this way and this way, and you can percuss over the sternum like this, and you can percuss over the scapula also like this. So this is how you can make the percuss. This is the direct percussion. And indirect percussion, there are when you are percussing the chest, there are rules of percussion are there. We use two fingers usually, the flexor and pixometer finger, and the flexor finger you will apply over the chest, and pixometer you will percuss over the flexor finger. So what are the rules? There should not be any gap between the surface of the percussing part and the finger. You should firmly apply your finger, not very painfully. Just it should be firmly applied, and there should not be any air pockets between the finger and the surface. And you should always percuss either in the intercostal space or over the rib. You should not overlap the finger on the rib and the intercostal space. And you should always percuss on the supposedly normal side first and abnormal side next. And when you are percussing for the border of some viscous, you keep your pexar finger parallel to the border, supposed to be the border. Likewise. So these are the rules of percussion. And another thing is, when you are percussing over the pexar finger with peximeter finger, your movement should always be at the wrist, not at the elbow, and it should be always equal. So for example, now I am we have deduced that in this patient the right side is the diseased side. So always percuss on the left side first here in this patient, and then go to the left side. And when the another point I forgot is you should keep the pexar finger and the other fingers should not touch the chest, because if they are touching, they will impede the vibration that is created by the percussion. And it is the vibration that is noted by your finger is more important than the sound that you are hearing. So these are the important things you have to keep in mind when you are percussing. And the only exception to the rule of percussing on the ribs or intercostal space is when you are percussing for the right border of the heart. When you are trying to percuss for the right border of the heart, you will go this way, breaking that rule. So these are all the rules of percussion. And another thing is tidal percussion is one thing where you will percuss for the chest from above downwards till you get the dull note. Once you get the dull note, that is supposed to be liver dullness on right side. So you keep your finger there and there itself and ask the patient to take a deep breath, and while holding the breath at the deep inspiratory phase, you percuss and see whether the dull note has been transformed to resonant note. That's if it is there, the tidal percussion is positive. That means the diaphragm is pushing the lever down, and that place is taken over by the lung. The lung has expanded to that area. That means if it is abnormal space, the pathology is below the diaphragm, it is not above the diaphragm. In the other cases, you will not find the tidal percussion with inspiration, the percussion dull note changing. That happens in case of pleural effusion and the consolidation or mass which is there at that place. That is one thing. And tidal percussion you can also do on the left side also. When you percuss from above downwards, as you come down onto the lower part of the chest, you will, the normal resonant note will be transformed to tympanic note, where the lower part of the chest is occupied by the fundus of the stomach. So when you get the tympanic note, ask the patient to take deep breath and see whether it changes into normal resonant note. That indicates that left side also diaphragm is functioning normally. These are the inferences that you will get out of the percussion. And another thing is you percuss over the supraclavicular fossa. Here there is a lot of fat pad is there. So here you have to percuss from neck going laterally to the shoulder. Here you will see the percussion note normally when the lung is normal. Sometimes there is a resonant note from the supraclavicular fossa is directly in connection with the resonant node on the suprascapular area of the posterior side. A strip of area almost 1 inch area is there where you can find the continuity of the resonant node, which is called chronic isthmus. So that is if it is obliterated, you will not find the continuation. That can happen in certain diseases like fibrosis of the apical part of the lung and malignancy also. The upper lobe malignancy also can cause the obliteration of the chronic isthmus. It can you have to this is taken because the upper lobe involvement is more common in both malignancies and bronchogenic carcinoma as well as tuberculosis. That is the reason why we positively look for chronic isthmus, whether it is normal, intact or obliterated. This is another point you have to remember. And some of the patients where the fat is more, you may not be able to properly get the percussion note. In that case, actually you can use, if you are not having sharp nails, protruding nails, you can just keep your finger like this, folding at the mid interphalangeal joint, and you can push this finger like this and percuss over this this way. This is called ortho percussion. This is one kind of percussion. You also can utilize it. When you are percussing, you may find sometimes very slight difference between the two percussion notes, whether it is there or not. In such cases, what you do is you try to first percuss over the supposedly normal side first and apply the amount of percussion note just to produce resonance, and then now apply the same amount of thrust on the other side, and if it is there not there, it is it can be confirmed that there is a slight diminution of the percussion note. This is called threshold percussion. So these are the ways of percussion in the conventional way. In the recent times, what they have done is this application of wrist for the tapping the pexar finger is not always possible to maintain the uniform thrust. So now what some people advising is to use your thumb to tap the other side, other finger, and you can use it the rotatory movement, which could be exactly the same. So this way you can use the thumb for the percussion. So this is another way of percussion. So direct percussion and indirect percussion also you can use wherever it is possible. Some of the times you may have to change the position of the patient to take advantage of using the thumb as the peximeter. So these are the points you have to learn regarding the percussion. See, the auscultation of the chest for respiratory system. This we always use the stethoscope, and the patient preferably be in a sitting position, and ask the patient to open the mouth partially and take breath a little bit more deeper and faster than what he usually takes, and then you auscultate. What you expect in auscultation of the chest for lungs is you will be able to see the respiratory sounds. The respiratory sounds, the same principle you have to use. You should auscultate on the normal, suppose it to be normal side first and the abnormal side next. So what you will observe, what are the normal breath sounds, what are the abnormal breath sounds, and whether there is any adventitious sounds. If so, what are the adventitious sounds? These are the points you have to observe while auscultating the patient. So when you are auscultating on the chest, the normal breath sounds, how they will be? The normal breath sounds are, the inspiratory phase is longer than the expiratory phase. Then the inspiratory phase is more louder than the expiratory phase, and there is no gap between the inspiration and expiration, and the quality of the normal sound is like a roaring sound of the leaves when you are sitting in a summer time in a forest. The movements of the leaves rubbing one another will produce a kind of rustling voice, they say. That's what you expect in the normal breath sounds. If that sounds are there, first you see what is inspiration and what is an expiration. You try to identify these things, and then know which is more longer, which is more louder, is there any gap between the inspiration and the expiration. These are the points you have to know, and ask the patient not to make any adventitious sounds that are arriving out of the mouth or throat. This is also very important. So what are the abnormal breath sounds? So this is one particular point many people feel very difficult to identify the breath sounds. So actually this is one thing, one part of the examination of respiratory sounds that gave a notion that respiratory system is the graveyard of a physician. It is not so. This is very easy to identify these sounds. As I tell you, just keep these things in your mind. So what is a bronchial breath sounds? There is other abnormal breath sounds are bronchial breath sounds. The bronchial breath sounds are again divided into three types. One is tubular, other one is cavernous, other one is amphoric. These are the three types of bronchial breath sounds. So when you are auscultating and when your questions for the normal breath sounds are not fulfilled, then it could be an abnormal breath sounds. So what is the abnormal breath sound? The bronchial breath sounds, tubular nature. These are akin to the sounds that you can hear over the trachea. You put your steth over the trachea and observe the inspiratory and expiratory breath sounds, and that will make the bronchial breath sounds. If the sounds are similar to this character but a little bit less intense, then it is a bronchial tubular breath sound. And what about the cavernous breath sounds? The cavernous breath sounds will have some echo type of sound with the bronchial nature, and that will be heard as if they are coming from a long distance. The cavernous breath sound is the sound which is coming from a deep hollow space. So that will have some echoing type of sound, and this bronchial breath sounds will have the characteristic. What are the characteristic feature of a bronchial breath sound? Actually is that there the inspiration is shorter compared to the expiration. In the otherwise, expiration is as long as inspiration, or sometimes it may be longer than the inspiration also. And there is a clear gap between inspiration and expiration. The expiration is louder than the inspiration. So it is just a reverse of the normal breath sounds. If you find these characteristics, then you have to identify the character by auscultating over the trachea to confirm that it is a tubular breathing, if it is similar to that. If you auscultate over the nape of the neck while asking the patient to open the mouth widely and take breathing, in that case you will hear the cavernous kind of breathing at the nape of the neck, and you compare whether it is similar to that nature, it is a cavernous breathing. And another one is amphoric breathing. Amphoric breathing is like the cavernous breathing but with a metallic tint. If you take a pen cap which is made up of metallic material, you will, if you make a whistle through that, by keeping tangentially and trying to blow air, you will be able to hear a whistling sound. That sound, if you are able to hear, for example, see this kind of sound with a little bit metallic tint, if you are able to hear, it is called amphoric breathing. All these three kinds of breath sounds, tubular, cavernous and amphoric, three breath sounds will have the characteristic features like the expiration is longer and the expiration is louder, and there is a definite gap between inspiration and expiration. These are the points which will make it a bronchial breath sounds, and the characterization up to you. This is, and there is sometimes a bronchovesicular breath sounds are there in certain of the conditions where there is a mixed pathology, wherein you will not be able to see the gap between the inspiration and expiration. The expiration is prolonged and louder, but there is no gap between inspiration and expiration, then it is a bronchovesicular breath. So now we will go to the adventitious sounds. Adventitious sounds are basically, one is crepitations and the other one is wheezes. These are the important adventitious sounds you expect in a respiratory case. Another adventitious sounds, others like pleural rub you may find, and suction splash when you do some special examination for hydropneumothorax. These are the adventitious sounds you will expect in a respiratory system examination. So what are the crepitations? Crepitations are bubbling kind of sounds. You will hear, they will occur in a flash moment of time. So the sound will come like a cracking, just a cracking. So a bubble has ruptured, or a bubble wrapper is there, that is rupturing, or sometimes this wrapper, velcro tape, when you are able to trying to separate the male and female of a velcro tape, that sound that you are getting, these are the kinds of sounds you will get. So the crepitations are again of three types, coarse crepitations and regular crepitations and fine crepitations. Coarse crepitations are they are the crepitations will have high pitch and a little bit of squeaky nature will be there, as you see in the bronchiectasis, because whenever there is a thick tenacious secretions producing the crepitations, they will produce this kind of crepitations. And ordinary crepitations you will find in cases like resolving pneumonia and all these conditions, wherever there is secretions which are of medium thickness. And fine crepitations you will find in certain conditions like interstitial lung diseases, and in the early stages of congestion in bronchial asthma and the early interstitial pulmonary edema and all, you will be able to see that. So these are the crepitations. So if you just blow a small tube into the fluid and try to make bubbles and rupture, you will be able to see the crepitations like sounds, that is crepitations. Whereas the fine crepitations you can mimic by just drawing your hairs onto the nearer to your ear and just try to roll over the hairs, you will be able to find the sound which is akin to fine crepitations. And next thing is wheezes. What is wheeze? Wheezes are the sounds, another abnormal sounds. The wheezes are the sounds which are long duration sounds and they are musical in nature. So these sounds are like when somebody is squeezing an inflated balloon. Suppose if you inflate a balloon and partially stretch the neck, the partial air going through the balloon will produce that kind of sound which is long and musical in nature. This is called this thing. The sounds of wheezes, depending upon the area from which they are occurring, will have different kinds of frequency and their intensity and the character. All these things you will see. So these are again polyphonic and monophonic wheezes, you will say. Polyphonic wheezes are different frequency sounds, different intensity of the wheezes occurring in the same place are called polyphonic phases. Monophonic wheezes are only one kind of note and one kind of wheeze is there, which is heard, maybe heard all over the area. That is only a transferred sound from one area. So this kind of monophonic wheeze is indicative of some major bronchial obstruction. So these are the abnormal sounds, regular abnormal sounds. If you take the pleural rub into consideration, sometimes when there is a dry pleurisy and the pleura thickening and the pleurae are making excursions over one another, you will find the pleural rub. How the pleural rub will be? It is a sound which occurs usually during the inspiratory phase or expiratory phase, depending upon which phase it is rubbing the pleura. The pleural rub can be mimicked by keeping your palm over the ear and try to scratch over the dorsum of the palm. You will be able to hear a cracking sound that is akin to the pleural rub. And if you want to see the suction splash, you make somebody take some water and fill the stomach and try to just shake him while auscultating over the epigastric region. You will see the stomach fluid that is making a sound that is called a splashy movement, that is suction splash. These are the abnormal sounds you can expect in the respiratory system. So how you will devise the various sites where you have to examine the patient. You keep your steth and always try to auscultate with the diaphragm part and try to ask the patient to open the mouth partially and take deep breath at a little bit faster pace, and always try to auscultate on the supposedly normal side first and compare the same site on the corresponding site on the other side, and try to do the infraclavicular areas, mammary areas, inframammary areas, and try to examine a full respiratory cycle at each area. And the same way suprascapular area, infrascapular area. Here for the sake of pace I am auscultating fast, but try to see at least one cycle at each area while examining the auscultating. And here also there is especially on the posterior side, the suprascapular area is corresponding to the posterior segment of the upper lobe. Interscapular area is corresponding to the sixth segment, that is the apical segment of the lower lobe, and the infrascapular area is corresponding to the 10th segment, that is a posterior segment, posterior basal segment of the lower lobe. So these are the even segmental anatomy which corresponds to the abnormalities in these areas. That's how you have to make the examination. When you are auscultating, you will see the sounds that are transmitted to the chest wall with the stethoscope also, which is called vocal resonance. The vocal resonance goes hand in hand with vocal fremptus, but because it is with the ear, so it will be more sensitive. So this also follows the same rule as the vocal fremptus. You will try to auscultate the normal side first and abnormal side next in the corresponding areas on both sides while the patient is uttering the words. Likewise, you will examine the posteriorly also. That's all. So this is what how you will do. And one thing you must remember most importantly is that the vocal resonance and vocal film test, they go hand in hand. So you must remember that if the vocal film test is increased, vocal resonance also increases. It is not like vice versa. So you should, some of the times people will be confused and sometimes they say vice versa. It will never happen. This is a rule that vocal film test and vocal resonance will go hand in hand. Vocal resonance only is to see the vibrations in a magnified way by ears. This is by the touch and this is by the ears. That's the only difference. So you should follow the same rules as the vocal film test while doing the vocal resonance. That's all. This is about the breath sounds.